Okay, so this is chapters 32 and 33. So we're going to talk about, it says diabetes mellitus and the metabolic syndrome, but it's also going to cover endocrine. So the first several slides are over endocrine, and then we'll spend the rest of the time talking about diabetes. So the endocrine system it really consists of hormones. So when we're talking about a way for the brain, the body to communicate with cells that are a long ways away. Okay, so essentially that's what's going on with the endocrine system is that we'll produce a hormone in one place, and then that will move into the blood. Okay, so that's another very important fact about the endocrine system is that the hormone is released into the blood, and then once it's in the blood, it can move to wherever. Okay, and it'll only affect a cell that has a receptor for it. Okay, so if this particular cell here has a receptor for the hormone that was released, then that will have an effect. Okay, so endocrine implies release into the blood, and hormones are the signal molecules released into the blood that have their effect at a different location. Okay, so a cell, as I said, a cell will only respond if it has receptors for the hormone, and sometimes you can have upregulation or downregulation of the receptor. So if a receptor is sometimes overactivated, then that receptor will downregulate or upregulate. If it'll upregulate if enough of it isn't produced. Okay, so different cells, like I said, different cells respond differently to the same hormone. So we want to talk about, first of all, what normally happens, and this is by no means, so we're going to talk about the hypothalamus and how in the brain, I guess I don't have to draw this, in the brain, the hypothalamus is it's actually a brain region, so it's neuronal tissue. And it gets a lot of information from the periphery. And not just from the periphery, but you can think about a stressful thought, and it will actually then, through the hypothalamus, will release what are called tropic hormones that will then cause the pituitary to release another hormone, which can then go down and activate your adrenal gland, so you release stress hormone. Okay, so somehow, whether it's a signal from the pituitary or from the periphery, or it's something that just you came up with it out of your own mind, you will move through the hypothalamus, and then the hypothalamus communicates with the pituitary. Okay, so that's, like I was going to say, that's by no means the way all hormones work, but many of them do. And a lot of the control you have over some of the cell functions in your body actually goes through this axis, the hypothalamus, pituitary, and then whatever the endocrine gland that you're trying to control is. So many of the things that the hypothalamus kind of tracks and controls, it doesn't personally, if you can say that about a brain region, track them, but signals come to the hypothalamus, and it all goes through the hypothalamus. So that includes temperature, blood osmolarity, ions, nutrients, emotions. Okay, so we already mentioned that, something like fear or something like that can cause a system-wide response by going through the hypothalamus. Pain, growth and development, sex responses, things like sperm production and keeping like a monthly cycle, menstruation cycle. Other hormone levels of hormones that are circulating in your body all the time. Okay, so the hypothalamus releases tropic hormones to the pituitary, and then the pituitary releases other tropic hormones, which will activate the actual gland. And I want to add that I usually don't make a big deal about posterior versus anterior versus posterior, because most hormones are released from the anterior pituitary. The only two that are released from the posterior are vasopressin, which we also know of as antidiuretic hormone, ADH, and oxytocin. So those are the only two that are released from the posterior that we'll ever talk about. Okay, so let's first talk about, let's kind of follow this process through with an example, and we're going to use as our example the thyroid hormone. So any of these inputs, so sleep, cold temperature, stress. So these are just a few of the things that may require the activation and release of thyroid hormone. So these things can be communicated to the brain, and then via the hypothalamus, it will cause the hypothalamus to release something called thyrotropin or thyroid releasing hormone. Okay, so thyroid releasing hormone, TRH, is released from the hypothalamus, and it just goes a short distance down here to the anterior pituitary. And that will trigger the anterior pituitary to release something called thyroid releasing or thyroid stimulating hormone, which will stimulate the thyroid gland. The thyroid sits down in the lower part of your neck, and then the thyroid gland will respond by producing the thyroid hormones. And the thyroid hormones are called T3 and T4. Now, T3 and T4, the 3 and the 4 represent how many iodine atoms are attached. And so then once the T3 and T4 are made, then they will provide negative feedback, and they'll go up here and they'll block this, and they'll say, okay, we're here, and so that will shut down the release of TRH from the hypothalamus and TSH from the pituitary. Okay, so that's a negative feedback. It's kind of self-reliant. It's kind of interesting how that works. Okay, so now I mentioned that iodine is the T3, the thyroid hormone requires iodine, and that's one of the main places that you'll ever see iodine in the body. But let's say you don't have enough iodine, then what happens is that the thyroid gland is trying to make something called thyroid globulin. It's a precursor, and it makes that, and then it waits for the iodine to show up. Well, if you don't have enough iodine in your diet or for whatever reason, then it will continue to make this precursor molecule, and your thyroid will just get larger and larger. Okay, so it's getting larger, and that's what's called a goiter, and yet you're still not making enough thyroid hormone. So your hypothalamus continues to release TRH, your pituitary continues to release TSH, and your thyroid gland will continue to get larger and larger and larger. Okay, and that's what a goiter is, and that's what causes it most of the time is this lack of iodine. So iodine deficiency causes incomplete manufacture of T3 and T4, so it's not released fast enough, but yet the TRH and the TSH continue to be released. Okay, so there are a number of hyperthyroidisms. So that means that your thyroid gland is overactive. Okay, so in general, that's what we're talking about. Hyperthyroidism, the thyroid gland is overactive. And while the thyroid hormones have a lot of effects, but in general, they all kind of point to an increase in your metabolism. Okay, so an increased metabolic rate, and we kind of see that from the symptoms of what happens when you overproduce thyroid. Now this can come from thyroid hormone. So if it can come from thyroid tumors, that could cause it to be overactive. And then there's this Graves' disease. Okay, so Graves' disease is an autoimmune. We already talked about this a little bit, but it's autoimmune disease. It's a type 2 hypersensitivity, essentially where you're making these antibodies, and these antibodies are stimulating the thyroid. So they're binding to the thyroid stimulating hormone receptor sites, and they're stimulating it instead of the TSH, which is supposed to stimulate it. And since these aren't controlled, then you just have this overproduction of thyroid hormone, and you're actually producing thyroid hormone. So if we want to think about what the thyroid hormone does, overactivating it causes weight loss. Now hair loss, that's a little different because you get that with hypothyroidism too. But in arrhythmia, so it causes some heart issues. Bone loss, it causes bone loss, and heat intolerance. And if you think about what's happening when you you're cold, one of the things that will occur is thyroid hormone may be increased, and that will then cause you to shiver. It increases metabolism, and metabolism will generate heat. So if you're already producing too much, any kind of extra heat is just going to be confounded, or it's going to be magnified. So you have heat intolerance. Sleep disturbances can occur, and like we already mentioned, goiter. So in this case, it's because you're overactivating it, and it's simply making too much thyroid hormone, and so that's going to cause growth of the thyroid gland. And then this exophthalmos, I have a hard time with that word, but this is what we see in this picture. So even though this woman is completely relaxed, uh, her eyes are kind of bulging out, and that's because they're actually being pushed out through too much connective tissue, so connective tissue deposits that happen. And there are lots more, but like I said, they all sort of point to this increase in metabolism that's going on. So weight loss, things like that. Hypothyroidism is when you are not making enough, so you don't have enough thyroid hormone. So some of the symptoms are pretty much just the opposite. So it's a decreased metabolism, and some of the examples are Hashimoto, which is an autoimmune disorder that prevents the production of thyroid hormone, so thyroidectomy, so you have your thyroid gland removed or part of it. And then iodine deficiency. And iodine deficiency, yeah, if you don't have enough iodine, you're not going to make enough thyroid hormone. So we see kind of the opposite. Weight gain. We'll still see goiter, because kind of like what I mentioned if you're lacking iodine, then you're not going to be able to make enough thyroid hormone. So but yet it's your thyroid gland is going to try, and it's going to make this precursor, and so you're going to get goiter. So you can see that shows up on both categories. It just is a completely different reason why. So iodine deficiency. So if you were to test someone, they would have lower iodine in their blood. In the case of iodine deficiency, or yeah, right. So cold intolerance, sorry, and if you think about that, that means that if you get cold, your body doesn't really have a way to respond. Okay, so you aren't able to increase your metabolic rate to generate heat, and so that means that when you get cold, you have a hard time getting warm again. Reduced heart rate, high cholesterol comes from this, fatigue. So you're just tired all the time, and low energy, that kind of thing comes with hypothyroidism. All right. So let's talk also about stress hormones. Okay. So the main stress hormone is cortisol. It's a glucocorticoid, which means that it's made in the adrenal gland, and it affects glucose. Ultimately, is one of the things that it affects. So it follows the same pattern. CRH released by the hypothalamus, and then which is corticotropin releasing hormone. Then there's acetylcorticotropin hormone, which is ACTH. You don't have to know exactly what those mean, but it's hypothalamus to pituitary, and then to the adrenal gland. Okay, so sometimes you'll hear about that as being the HPA axis. So hypothalamus, pituitary, adrenal. Cortisol, like I said, is the stress hormone. It's released from the adrenal cortex. And I point out again, the renal in adrenal comes from the fact that it sits on the kidneys. Okay. It increases blood glucose. It can increase the sympathetic nervous system response, so your fight or flight response. It mobilizes free fatty acids in case you need those for energy. Breakdown of muscle tissue. Catabolism, which is kind of related to this breakdown of muscle tissue, and it elevates plasma proteins in case you need those to produce more enzymes or something like that. So really, what it's doing is it's mobilizing these amino acids. It's it's getting fats ready in case you need that. It's really just getting you ready for that fight or flight type of response. Okay. And so you can see that chronic stress or a long or some kind of a chronic stressor that causes the continued release of cortisol cannot be a good thing, and we'll see that in the next slide. So it also, in addition to increasing all of these things, it also suppresses the immune response. Okay, so the immune and inflammatory system. So it's going to decrease that type of response. So it leaves you more vulnerable to infections. Okay, so a couple of disorders that come from disruptions in cortisol release include Cushing's syndrome. Cushing's syndrome is the overproduction of cortisol, and that can be from any cause, whatever's happening, whether it's chronic stress of something going on, and we're talking about a significant stress response. Medications like prednisone can increase the cortisol that's released. Pituitary tumors may increase cortisol release as well, and these are all part of Cushing syndrome. And so you can see that there's some weight gain, thin wrinkled skin, poor wound healing, yeah, because it affects the immune response, and osteoporosis, so breakdown of bone material, muscle wasting and weakness. And so this is this is not a good situation. Well, then there's Addison's disease or Addison disease, and that's where, so Addison is the opposite. That's where your adrenal cortex itself is not producing cortisol. Okay, so this could be autoimmune. So you're attacking the cells or the mechanisms that release cortisol. Tuberculosis can cause this, can contribute to this as well in some cases. And so you see again some of the some opposite effects here: loss of weight, emaciation, anorexia, hypoglycemia. Your blood levels, your blood glucose levels tend to fall because and I didn't mention this, but one of the things that cortisol does, I think I mentioned it later, but one of the things that cortisol does is it increases glucose levels. So if you're not producing enough, you may see lower glucose levels. So hypoglycemia, poor tolerance to stress, obviously, if you can't produce the stress hormone, fatigue, muscle weakness. Okay. Okay. So when we're that's kind of those are kind of the hormonal responses that I want you to know about, and some of the disorders that go along with them. So I kind of want to start talking about energy and how that's going to relate to diabetes, because that's mostly what we're going to talk about. But first of all, I want you to understand this concept of metabolism. Now, you may have learned this before, but we keep talking about the increase in metabolism. Metabolism is actually made up of two things. It's made up of breaking molecules down and then building those molecules up. Anabolism is the building up. Okay, so that's putting smaller subunits, smaller things together to make something larger. So that would be, for instance, you may take free amino acids and you may build those up to build muscle tissue, or to build the actin and the myosin that cause a muscle contraction. Okay, so that's anabolism. So you hear about anabolic steroids. That's building things up. Catabolism is breaking things down, and we kind of see that example here. When you eat something, you may eat like you may have for your dinner, you may have proteins and polysaccharides and fats. Well, those need to be broken down through catabolic processes, and the proteins will be broken down into amino acids, monosaccharides, and fatty acids. So those things can be broken down, and then I'm just showing here that those things can then be used to make energy, because that's a lot of what we're going to talk about. So molecules that are provided to cells to make ATP include these things: proteins, carbohydrates, and fats. So carbohydrates are the favorite. Okay, so that is what your body is really set up to do. The cells and the mitochondria are set up to use glucose, and so glucose is the cell's preferred energy. Now, if you're low on glucose, which can happen, then you can use fatty acids. So it happens all the time. In fact, sometimes in the morning we're burning fatty acids instead of glucose because we haven't eaten in a very, very long time. So fatty acids they're the most efficient form of energy, but the number of steps essentially to turn fatty acids into energy is a little bit higher. Okay, so it takes a little longer and there are more steps involved than it was with glucose, which is why glucose is the preferred source. Now, last and least actually are proteins and amino acids. Your body really doesn't want to break down and use proteins and amino acids as energy. It can do it, but it doesn't want to. It's the least preferred. So this is a lot of times what you see with, you see these old pictures of like POWs that have been starved for a very, very long time, and they actually will start breaking down muscle tissue, taking proteins and amino acids from muscle tissue and use those as energy. So that's not preferred. So the supply and storage of nutrients is controlled by, well, the liver. The liver controls a lot of them. Okay? The liver supplies them, and the liver stores them, and it can make them. It can make certain forms of nutrients. It can make glucose, okay, for instance. And we'll talk a little bit more about that. So it stores, processes, and mobilizes a range of nutrients, but it can put together a triglyceride, so it can build up triglycerides, and then it'll usually shuttle those off to adipose tissue. It can make cholesterol, and same thing, it'll move that maybe to adipose tissue, or it may move it right to cells. Cells need cholesterol, cells need triglycerides. Amino acids, there are some amino acids that can be produced there, or it may just be storing amino acids in case you need them later. So storage or processing. Some hormones can control our nutrient levels. And so this is kind of where we're starting to get into this, is insulin and glucagon can control how much glucose is available. So insulin and glucagon are both made in the pancreas, and they are the main hormones directly involved in glucose storage and mobilization. Okay? So hopefully that makes sense. We need glucose. It's your body's preferred energy source, and the main way to control the increase, if we want to increase how much glucose is in our blood, then we can release glucagon from the pancreas, from alpha cells of the pancreas. If we want to decrease, so we have too much glucose, we just ate a meal or something like that, then we can release insulin, and insulin will be released from the beta cells of the pancreas. Now, other hormones, I kind of already mentioned this, is cortisol and then thyroid hormones. So these can also increase blood glucose levels. So we can't forget about those as well. So there are some other hormones that have an effect on glucose. Epinephrine, your fight or flight response. Well, if you're being attacked by something, sure, why not? We'll increase glucose for that too. That could be kind of handy. And there's this term here, glycogenolysis, which is glycogen is just this chain of glucose molecules, and it will break those down. Oops, I didn't mean to cross that out. But it'll break those down and then release them as glucose into the blood. Okay, so that's something that can happen when you're exposed to epinephrine, and a lot of these things will work together to really increase blood glucose. Okay, so and epinephrine also inhibits insulin. So not only is it mobilizing glucose and from glycogen, but it's also telling the insulin, nope, I got this. So it reduces the insulin release, and so the insulin isn't out there to get rid of that glucose. Okay, so usually that's a short-lived kind of thing. So So it's a temporary thing. Now it also breaks down fats, because remember, if you're breaking down fats, then those can be used as energy as well. So when you release epinephrine, you're just getting your body ready to do some real work. Okay. Growth hormone also has this effect, increase in protein synthesis. Well, we're talking about growth, so that makes sense that you're going to have more proteins being made. Mobilization of fatty acids. Well, if you're growing, that means your cells are getting larger, which means that you're going to need more phospholipids, so you're going to need more fatty acids for that. And it also antagonizes the effect of insulin. So it kind of shuts down the insulin and says, nope, we're going through a growth phase right now. We're going to need that glucose. So insulin, you can just take a back seat for a little while. And then we already mentioned cortisol, or stress hormones. Okay. So, and those will cause an increase in the production. Gluconeogenesis, break down the word. Glucose, neo means new, and genesis is to produce. So producing new glucose. Okay, so stress hormones can cause that to happen as well. Okay, so processing and storage of glucose. I've already mentioned, and I kind of drew it on the previous slide, but this is kind of a picture of glucose, or representation, or I'm sorry, of glycogen. So this is kind of a representation of what glycogen would be. It's a little more complicated than that, but it's essentially just this long branch chain of glucose, and it's a great way to store it. You have all of this glucose, rather than just having it, freely floating around. You just make this one giant molecule, and then when you need the glucose, you can just break these guys off one by one and release the glucose into the bloodstream. So it's a nice way to store it. When glycogen stores are full, so we've had this excess glucose, and then let's say we're in the liver. Well, once we've kind of made all of the glycogen that we can make, then we'll start turning that glucose into fatty acids. Okay. So it's converted into fatty acids, and then we'll make triglycerides out of that. And we'll send those triglycerides to adipose tissue. So the thing to remember is that any glucose that your body has, it's energy. And really, that's what the body wants, is it wants energy. And so any glucose that you ingest is going to stay in your body. And we have all of these ways to store it. And pretty much triglycerides, that's almost a limitless way to store excess glucose, because it's a fat, and the glucose can turn into fat. And this is a picture of a triglyceride. So when glucose levels are depleted, so we've run out of glucose, well, then we go through this process of gluconeogenesis. We make more. Well, how do we make more glucose? How do you make glucose from, well, you can't make it from nothing, but how do you make glucose? You can use some of these other molecules, like amino acids. Okay, your body doesn't prefer to do this. You can make amino acids, make it from amino acids, and then glycerol and fatty acids. Now, what is glycerol? Glycerol is just this little bit right here of a triglyceride. Okay, so it's 3 carbons. Glucose is a 6-carbon sugar, and so you can just sort of wrap this around, and you can make glucose out of it. Fatty acids, usually these are broken off a couple at a time and those can be used to make new glucose. The fatty acids are the tails here. Now, one of the things that happens when you make new glucose, so utilization of fatty acids or amino acids, is energy. So one of the things, and glycerol, but one of the things that's produced are these things called ketones. Okay. So in fatty acids, glycerol, and amino acids are catabolized, broken down, to make ATP. They form acidic ketones. So when these are used as an energy source, when they're broken down to either make ATP or when they're broken down to make new glucose, they can form these acidic ketones. And that can, in a diabetic, and it can happen, I suppose, to anyone, but it's common in type 1 diabetics, is this ketoacidosis. Okay, and so because these ketones are acidic, the blood pH falls, and then you have acidosis, which from the production of those ketones. Now, let's talk about how this is happening so let's kind of drill down and talk about how insulin and glucagon are released and from where they're released. Now, most of us, know from either previous classes or just paying attention that the pancreas is responsible for the production of insulin. It's also responsible for the production of and the release of glucagon. Sorry. So what it does is it releases, there are little islet cells in the pancreas, and these are called either pancreatic islets or the islets of Langerhans or pancreatic islets of Langerhans. But most of the pancreas is exocrine function, which means that it's being released into, well, in the case of the pancreas, most of it is it's mostly digestive enzymes that are being released into the lumen of the intestines, in the small intestine. But there are these little islands that are islands of cells. That's kind of how I think of it. That are responsible for releasing glucagon and um, and insulin. And so if we look at these little islets, so this is a pancreatic islet of Langerhans, and you can kind of see here. So this is kind of the outline of it there. And you can see packed in there are these things called alpha cells and beta cells. And the alpha cells are responsible, well, okay, we'll go in the other order. So the beta cells are responsible for the release of insulin. Okay? So when these guys, they can sense glucose. Essentially, they have little glucose transporters that allow a little bit of glucose in. The more glucose shows up in there, and then that will trigger the release of insulin. So when too much glucose is found, or when high levels of glucose are found in the blood, then these will release insulin, and the insulin will move into, and these guys here are just capillaries that are running through this. And so it'll release, and the insulin will move out of these cells, and it'll perfuse out into the blood. Okay, so beta cells release insulin when they detect high blood glucose levels, or when triggered by the gut, by gut-derived hormones released by the stomach after eating. So sometimes when we eat, sometimes even when we smell food, we'll have this increase in insulin release because it's getting ready for this spike of blood glucose that it knows is coming. Now, alpha cells release glucagon. So when you don't eat for a long time, then your blood glucose levels start to fall. Okay, so we release glucagon from alpha cells, and then that will, trigger the adipose tissue, primarily the liver and skeletal muscle, and say, hey, our blood glucose level is low. We need to increase the blood glucose. Okay, so that usually happens between meals, and there are also some others, but one that's shown here, delta cells that produce somatostatin, which extends the time food is in the stomach and this will block insulin and glucagon. So in a way, this is released to increase the glucose levels. Okay, so it kind of works against the insulin in some ways, but it's doing it for an overall more homeostatic, more smooth increase in blood glucose. Okay, so glucagon. We'll talk about glucagon. Again, it's produced by alpha cells in the pancreatic islets of Langerhans. Maintains blood glucose between meals and during periods of fasting. Able to initiate glycogenolysis. Again, glycogenolysis is the breakdown of glycogen into individual glucose monomers. So, which I say here, in the liver, glycogenolysis in the liver for quick increase in glucose. So the breakdown of glycogen to release glucose monomers. Remember that's primarily happening in the liver. Can stimulate gluconeogenesis in the liver. So now the liver is going to start making glucose. Okay, and remember, it's making that from fatty acids, it's making it from amino acids, and and that can throw off these ketone bodies. So we don't want to forget about that. That's one of the byproducts. Usually your body can handle that, and it's just a normal process, and those extra ketones are not a big deal. Um, but it can become a big deal. Okay. And again, glucagon is regulated by blood glucose levels. Okay, so glycogen to producing glucose from glycogen, glycogenolysis, producing fatty acids from fats is lipolysis. Lysis means to break down or cleave. And then making glucose from amino acids is gluconeogenesis. Amino acids and making it from fatty acids too as well. Okay, so what are the effects of insulin? Well, it depends. It depends on the cell type. Remember this, okay? So remember this for the exam or for whatever exams that you're thinking you might be taking someday. Insulin has its effect primarily on these cell types: adipose tissue, skeletal muscle, and liver. The effect in adipose tissue is going to be centered around fat, okay? So it's going to increase glucose uptake, so the excess glucose can be turned into fats. It's going to, which ties right into the increase in triglyceride synthesis. So we put glucose into the adipose tissue, and then we turn it into triglycerides or fat. And it's going to, if we've got extra glucose, if insulin is being released, that means we've got extra glucose, we've got plenty of energy, so there's no reason to break down fatty acids, so it's going to decrease lipolysis. Okay, so hopefully that makes sense. Skeletal muscle, it's also, all of these are going to increase the uptake of glucose, because that's one of the things that insulin does. In skeletal muscle, uptake of glucose increases glycogen storage, so we're going to store it as glycogen in skeletal muscle for sure. Increases protein synthesis, so there may be, so this is an increase in enzymes or anything else that needs to be produced to deal with the extra glucose. The liver, you're going to see, well, a couple of things. So it's kind of the liver does a lot. So it's going to increase glycogen synthesis, which we also saw in skeletal muscle, but it's also going to increase triglyceride synthesis, which we didn't see in skeletal muscle, but we did see in adipose tissue. And since we have extra glucose, it's going to decrease gluconeogenesis. So if I ask a question about what the effect of insulin is on any one of these cell types or these tissue types, then you just have to sort of think, first of all, what makes sense. So if it's adipose tissue, it's going to be focused around, making fats and decreasing the breakdown of fats. Skeletal muscle tissue, well, you're not going to be making fats in skeletal muscle tissue. Okay, they're going to recruit fats from somewhere else usually. But you are going to increase glycogen because you want to have a quick, you want to, if you need it, have quick access to glucose, and glycogen is that. And then in the liver, you're doing both. Okay, you're doing both, and you're decreasing the production of new glucose. Okay, so it kind of makes sense. All right, so insulin, when there is, so how does the, I guess the question is, we have this insulin release and it's decreasing glucose in our blood, but exactly how is it doing that? And we've talked about how glucose moves into all these cells, the adipose, the skeletal, and the, oh gosh, I can't think right now, the adipose, the skeletal, and the liver. Well, how does the glucose move in, and how does the insulin cause that to happen? Well, there are receptors on those particular cells. Remember, hormones they only have an effect on cells with a receptor. Well, there's a receptor for insulin on those cells. And so when the insulin binds, it causes stored, this is maybe a new concept for some people, but there are these little vesicles that are holding on to glucose, what are called glucose transporters. And in here, when they're kind of sequestered away in the cell and they're just sort of sitting there, they're these transmembrane transporters. And so they're just kind of sitting inside the cell, not really having any effect at all. But then when insulin binds, it causes the second messenger system to say, hey, we need these out here. And so this little vesicle here holding on to these will come over here and it'll fuse with the membrane, the cell membrane, and it'll insert these glucose transporters right into the cell, membrane. And once that happens, then the glucose can start moving in. Okay? And then they will disappear after a while, after the insulin stops binding, maybe when glucagon um, shows up, whatever. Um, but these things will kind of keep moving back and forth from being sequestered and hidden inside the cell to then moving back out and being activated. Okay, so insulin binds to and activates a receptor in the target cell's intracellular signals are generated that result in the insertion of these GLUTs or glutamate or glucose transporters into the cell membrane, and then the glucose will move through those membranes or through those transporters into the cell. Okay, so now we can start talking about diabetes as a disease. Diabetes in general came about because it was shown that there was an increase in urination, there was an increase in thirst, and we also see an increase in blood glucose. Okay, so diabetes now is an abnormality, and we sort of focus on this. It's an abnormality in blood glucose regulation, and nutrient storage related to an absolute or relative deficiency of insulin. So we also focus it around insulin and or the resistance to the actions of insulin, and that's where we start talking about how insulin may be released, but it just doesn't have any effect. Okay, so essentially in diabetes, you either can't release insulin or you can't respond to insulin, and so your blood glucose levels are more difficult to control. Okay, you can't decrease the blood glucose, and so it tends to get higher. About 26 million people in the U.S. suffer from diabetes. Of those, about 1 million, or 5 to 10%, are of a type of diabetes called type 1, or insulin-dependent diabetes mellitus, IDDM. Okay, so that's only about 5% of all diabetics. The rest are type 2 diabetes mellitus. So type 2 is more associated with high blood glucose, insulin resistance, and a relative lack of insulin. So in type 1, you have an absolute deficiency of insulin. So your beta cells, it's an autoimmune disorder in type 1, and so your beta cells are actually being destroyed, and these beta cells are what are supposed to be releasing insulin, so it is absolute. In insulin resistant, it's a relative lack of insulin, so the insulin may be still being produced, but it's not having an effect, and it's not coinciding with the decrease in glucose. And so that's what we call insulin resistance. And insulin resistance is one of the biggest problems of type 2 diabetes, or it's one of the biggest problems in terms of what's causing type 2. Because you're still releasing insulin, it's just not having an effect. Now, another type of diabetes is gestational, and that's associated with pregnancy. It's not really known what's going on there, what's causing it, but we know that it tends to be associated in some ways with type 2. So a lot of people with gestational diabetes will go on eventually to develop type 2 diabetes as well. Okay, so it's almost like a trigger. All right, so type 1 IDDM, insulin-dependent diabetes mellitus, is the destruction of pancreatic beta cells. Okay, and that will prevent the release of insulin. So it usually comes on in young people, so it's more common in young persons, but it can occur at any age. And essentially what happens is your immune system suddenly decides that it doesn't want to have these beta cells anymore. It's a type 4 hypersensitivity, so that means it's mediated by T cells. So suddenly your T cells decide that that beta cells, or a protein on the surface of beta cells, suddenly it decides that that's the enemy, and it's some kind of a pathogen, and that it has to be destroyed. And that's in about 95% of the cases. Okay, so 95% it's a subcategory, type 1A. So 95% are autoimmune, and then there are some that don't have the autoimmune, but we don't know what causes it. We don't know why the beta cells are being destroyed in those people. So we're going to focus mainly on this autoimmune or type 1A mechanism. Like I said, it's autoimmune. There's usually a genetic predisposition. So a genetic predisposition means that just because your parents, maybe both of your parents, had type 1 diabetes, it doesn't necessarily mean you're going to get it. There's a predisposition to get it, so your chances are increased, but it's not a guarantee. So there's a genetic predisposition with environmental triggers. So that means it's something in the environment, whether it's a virus that you were infected by, or some kind of an allergen, or something you ate. It's really not known. There's a lot of research trying to figure this out. But there's a genetic with environmental trigger that leads to this T lymphocyte mediated hypersensitivity. And like I said, that's a type 4 hypersensitivity. The MHC, so remember HLA, which means human leukocyte antigen, is the same thing as the MHC we've been talking about. So this is strongly associated with the development of type 1 diabetes. So if you have an HLA that is similar to your parents, then that's what we generally see in people who inherit it from their parents. We see a similarity in this HLA or MHC. Like I said, more common in young persons, but can occur at any age. And there's absolute insulin dependency, or absolute insulin deficiency, and that means you need insulin replacement. And also, we already mentioned it's kind of prone to ketoacidosis, which we'll say a little bit more about. Okay, so since this is the most common, we're going to spend a little bit more time talking about type 2, and it's also a little more complicated. Type 1 is pretty straightforward. You've destroyed the beta cells. You can't make insulin. Type 2, however, is characterized by insulin resistance. Like we said, we're still making insulin. Insulin is still being produced, and in fact, insulin can be elevated, and yet you also have elevated glucose. Okay, so even though you have elevated insulin, you still have elevated glucose. So the pancreas produces insulin, but the insulin has little or no effect. Okay. Now, over time, and so this is usually the way it begins, and you can take medications that will help mobilize, or will kind of do some of the things that insulin does. So you can do that in the beginning, but eventually you may, or it'll increase the amount of medications will sometimes increase the amount of insulin, but eventually your beta cells also may become damaged in type 2. Okay? And that will impair insulin release, and sometimes will require insulin injections. Okay? So even though you have insulin resistance, then that can be a real contributing factor. And so you really want to, for someone who has type 2 diabetes, you really don't want to get to this point, because it's kind of a confounded problem, right? Now you're not making insulin, and you take insulin injections, and your cells aren't as responsive to insulin, so it can be a real problem. Now, this is kind of a big deal. Over 90% of newly diagnosed cases are type 2, and it usually, and this is another reason why it's such a big deal, is it usually occurs in people over 30, but that's changing. So a lot of younger people are starting to develop type 2 diabetes. It used to be kind of called the old age diabetes. Well, not so much anymore. That age at onset is kind of ticking down. And it's progressive. So once you are diagnosed with type 2 diabetes, then your chances of getting rid of it are low, very, very low. But the chance that it's going to get worse is pretty high, unless you really take steps to stop that progression. Okay, so what is insulin resistance? It's not known exactly what's causing the insulin resistance. There's a lot of research on it, and it may be downregulation of the receptor, but most research has shown that that's probably not the case, that actually insulin, the receptor's there, insulin binds to the receptor, but something is getting messed up in here. So insulin is supposed to cause all of these things, production of fatty acids, whatever, depending on the cell, uh, new glycogen being made. It's supposed to cause all of these things to happen, but that doesn't take place. And so somehow the second messenger signal gets kind of mixed up. Glucose transporters aren't mobilized and moved to the membrane. For whatever reason, the insulin binds and the insulin is released, and the insulin may bind, but it won't have the effect. So there's a reduction in glucose uptake, and then one of the effects of glucose is to decrease gluconeogenesis and in the liver. So if you remember back to the effects of insulin, so it's supposed to make more glucose, or it's supposed to stop the production of more glucose. Well, it doesn't have that effect either, and so even more glucose is being made by the liver. Okay, so I already mentioned this. Over time, glucose may actually inhibit the secretion of the insulin from beta cells, and then that will cause more glucose to be released, which is going to inhibit it even more. And so this is where you kind of get into that danger zone where you may actually need supplemental insulin even if you're type 2. Okay, so what's the development? What's causing this? What is causing the progression? And really, a lot of times it just comes down to obesity. I don't mean to downplay that. It's just obesity, but that seems to be the biggest trigger, the biggest thing that's associated with the development of type 2 diabetes. Specifically, it's an increase in obesity around the middle regions. Okay, so highly associated with obesity, progression is associated with high fasting plasma glucose, obviously. Okay, so we can see that if you have high plasma glucose, that it's not being controlled, and that's sort of that feedback, that progression that's taking place. A high BMI, weight gain means that, I mean, if you're gaining weight, your type 2 diabetes is going to progress. Um, High plasma insulin. So we also see that. We also see initially an increase in insulin because that negative feedback. It's trying to get rid of the glucose, but after a while, it just sort of gives up, I guess, so to speak, in a physiological way. And younger age. So if you're younger, then you're going to see more progression. So because something has triggered this type 2 diabetes, and if you don't get a handle on it very, very quickly, that same something that caused it to happen at a younger age is going to cause it to progress more quickly. Um, so like I said, once type 2 diabetes develops, it's very difficult to reverse. And as usual, prevention is the best bet. So controlling weight, controlling high saturated fat intake can help a lot to offset it, especially if it's in someone's family, um, because there's a genetic component to this as well. If it's in your family, then you might want to be a little bit more aware of that as well. Okay. So also associated with the progression are chronic high free fatty acids. Okay, so this is one of these phenomena we see with diabetes, is an increase in these free fatty acids, and the free fatty acids can lead to more beta cell dysfunction, um, more insulin resistance, and reduction. So reduction in hepatic insulin sensitivity. So that's going to be a reduction in hepatic insulin resistance, which I guess is kind of related to this. And then you'll also see triglyceride accumulation in the liver. And those all kind of relate because we're making more triglycerides. The insulin says to stop making triglycerides, And so you see an increase, or you see an accumulation of these triglycerides in the liver. Um, Insulin resistance often improves with weight loss. Now, I've seen that. I've seen that before with certain people that if I mean some people when they're diagnosed with type 2 diabetes, they take it very seriously, and they try to develop an exercise regime. They try to lose weight, and that will help a lot. That will really slow down the progression and sometimes stop the progression. Now, there are stories about it being reversed and it's gone away, but typically you don't really see that. And if you do, it's not something that you would say, oh, you're cured, because you're still going to be at risk once you've developed it. Okay, so there's another disorder that's associated with type 2 diabetes. So we've already talked about obesity and just I don't want to say a general lack of health, but these things kind of point to that, but with more specifics. It's metabolic syndrome, or sometimes it's called syndrome X. And really, that's just a diagnosis that says that if you don't change your lifestyle, these are the things that are going to happen to you. And so we give it a name, we call it metabolic syndrome, and it's true. Once you see these symptoms that I'm about to talk about, then you're going to have an increase in cardiovascular disease, um, and diabetes, and well, mainly diabetes and cardiovascular disease. Okay, so you have at least three of the following, and so this is what's going to define metabolic syndrome is and our atherosclerosis, I guess, but that's kind of falls into cardiovascular disease. The other things I was thinking about all sort of fall under this big heading of cardiovascular disease. Okay, so anyway, metabolic syndrome, to know that this is what you're dealing with, or to define that you, I guess, have metabolic syndrome, would be any three of the following. So elevated fasting glucose, so over 100 milligrams per deciliter. Increased triglycerides, so if you see elevated triglycerides in a lab test, over 150 milligrams per deciliter. Reduced HDL. HDL is our high density lipoproteins. Some people call it good cholesterol or good fats, and really it is kind of, in a way, it's still a lipoprotein, so it still has fats in it, but it doesn't have as many, and so it will actually mop up some of the fats left behind by these LDLs that are just stuffed with fat. Okay, fat and cholesterol. So reduced HDL if it's below 50 in women and above 40 or below 40 in men. Okay, so that's an indicator. Elevated blood pressure, so high blood pressure, over 130 over 85. And then this idea of central obesity. So the bigger, larger belly, abdominal region. So increased adipose tissue around the waistline, and that's a big risk for type 2. So above 35 inches in women and above 40 inches in men. So going back to the good versus bad cholesterol, without going into too many details, because there's HDL, there are HDLs, there are LDLs, there are VLDLs, and they all carry different amounts of either triglycerides or cholesterol. Well, the LDLs tend to carry a bunch. They have a lot of fat. They're low density because fat is a little bit lower density and they have less protein. And so what seems to happen as they're moving through the vessels, they kind of, I don't know, I think of it as like wiping a table with a really, really wet paper towel. Um, yeah, sure, you're wiping it up, and there's water being carried by that paper towel, but it's just leaving drops all the way. Okay, HDLs are like a dry paper towel. Okay, so yeah, they're lipoproteins as well, but they don't have these as much um, fat in them. And so it's like a drier paper towel that kind of comes behind and it cleans up what the LDLs are kind of leaving behind. Okay, so that works kind of as an image. And that's kind of the way it works. But this cartoon kind of gives you an impression. The LDLs are just kind of leaking their fat all over the place, and the HDLs come by and they clean it up. Okay, so um, you do see this in diabetics. They have lower HDLs for some reason. There's a lot of research going into trying to figure out what that effect is and why that's taking place. Okay, so that was type 2 diabetes. Now we'll just say a little bit about gestational diabetes. Primarily, we're not going to say too much about it because we don't really know exactly what's causing gestational diabetes. We just know that it happens, and we know the risk factors, and we know who's affected. And so gestational diabetes, glucose intolerance, that's first detected during pregnancy. Okay, so that's what we mean by gestational. And women with GDM are at high risk for complications, pregnancy complications, like a mortality, fetal abnormalities, um, and they also may develop type 2 diabetes after delivery, 5 to 10 years after delivery. So they're also at a higher risk for developing just regular type 2 diabetes. Risk factors, well, if you have diabetes in your family, obesity is a big one. Sugar in your urine, well, which essentially indicates that you have high blood glucose. A history of some of these things: stillbirth, spontaneous abortion, fetal anomalies in a previous pregnancy, or previously large or heavy for date infant. So these are some of the things when they look back and they say, oh, who's getting gestational diabetes? And then they look back at some of the complications in pregnancies. That's what they see. An advanced maternal age, over 25. Yeah, 25 is not necessarily an advanced maternal age. I wouldn't classify that as advanced, but I would, but that's what they see, is that over 25 years old are maybe a little more likely to develop gestational diabetes, along with these other risk factors. Okay, so and then 5 or more pregnancies, which seems like a lot. So the ADA recommends a glucose tolerance test, and apparently they're recommending a glucose tolerance test for everyone. But so between week 24 and 28 for women who have not been previously identified as having glucose intolerance. An exemption could be, and this would of course be up to the physician, younger than 25, normal body weight prior to pregnancy, no family history of diabetes or poorer OB outcome, not members of high risk ethnic or racial groups. So if you don't fall into any of these categories, you can be not considered for that, but it's not a very difficult test to do, um, and so it's a tolerance test. It's not very difficult, so it seems like it would be a safe thing for everyone to have done. Okay, so diagnostic methods. How are we measuring our blood glucose? So we've already mentioned fasting blood glucose, and that just basically means so when your glucose levels, they kind of go up and down, up and down, up and down based on glycogen and glucagon. So I may be over exaggerating these this swing, but that tends to be what happens. So you have glucose that kind of increases, and then at some point it will level off if you don't eat anything. And so we're kind of going for that point. And usually after fasting for 8 to 12 hours, it kind of levels off into a pretty constant level. And so that's what you're looking at with the fasting glucose. Um, so you can also do casual or random blood glucose, and you just measure it at various times throughout the day, and kind of check what's going on with your blood glucose without regard to fasting. Now this one is a little more active, the OGTT, the oral glucose tolerance test, and essentially what you do with that is you administer orally, so you drink 70 milligrams of glucose dissolved in 300 milliliters of water. Okay? And that's going to cause a spike in blood glucose. And then if your insulin is being produced properly, it should return to normal after a couple of hours. Um, So yeah, with sufficient insulin release, blood glucose levels will return to normal within 2 to 3 hours after ingestion of a glucose load. So you can pretty directly see how well your body is handling glucose by having this test. That's the oral glucose tolerance test. Um, so higher levels of blood glucose remaining elevated for longer periods of time is what you're looking for. Now there's also the glycosylated hemoglobin, or HbA1c, a lot of times just called the A1C test. And what that does is on so in your hemoglobin's a protein, and this protein can be glycosylated. Okay, so that means that here we'll make those in blue. That means that this hemoglobin can start to take on glucose molecules. And how much glucose molecule, or how many glucose molecules that will attach to it, depends on how much glucose is in your blood. Um, when you first make hemoglobin, it doesn't have any glucose on it. It's so over time it will start collecting glucose. So you can kind of get an average of how much glucose you have over an extended period of time just by going in and looking at the blood and seeing on average how much glucose is on your hemoglobin. So blood cells last about 4 months, so you kind of have this average amount of glucose overall. So you can kind of tell over that period, so the previous 2 to 3 months, um, will give you kind of an average of how much glucose your hemoglobin has been exposed to over that time. So it gives an average. It doesn't just like look at what you had for dinner yesterday. It kind of keeps track of it over a period of time. So glucose entry into red blood cells is not insulin dependent, so that means that glucose can just go into red blood cells, but the rate at which it becomes attached to the hemoglobin depends on the glucose levels. Okay, and it's irreversible. So once it binds to the hemoglobin, it's just sort of there. Okay, so the ADA recommends corrective measures for HbA1c levels greater than 7%. We have those numbers on the next slide. And then you can do urine tests, and you can test for ketones, so the production of ketones in the urine, and that's for type 1 people and people who are prone to ketoacidosis. So you can kind of keep an eye on that. Now, these categories of risk. So you've got normal, and then you have kind of at risk. So normal is going to be a fasting glucose levels of below 100 milligrams per deciliter in the oral glucose tolerance test. Only need 1G there. Oral glucose tolerance test of less than 140. And then you have this sort of pre-diabetic, okay? Where you have impaired fasting plasma glucose or impaired glucose tolerance. So this is where you're kind of getting into the risk range. You're running the risk of developing full-blown diabetes. So diabetes itself would be a fasting glucose of greater than 126 and an oral glucose tolerance test level of greater than 200. So this is when you would make that diagnosis of diabetes. So diabetes management, type 1, you're always going to need insulin. Okay, so it's insulin dependent. Type 2, you can use other medications. So there are medications available, and most of these medications will have their effects on the adipose tissue and the hepatic tissue, and it's kind of trying to either stop gluconeogenesis, or it's trying to maybe increase the movement of glucose into these cells. In some cases, it might be trying to increase the amount of glucose that your beta cells are producing. So these medications there are several different types of medications, and sometimes they do several of these things. Like metformin will do a number of different things, and that's why it's the most used. But there's a range. There's a range of these, and it kind of depends on how you're expressing, I guess, and what the physician chooses to try and what works on you, really. So anti-diabetic medications, and then diet. So if you're type 1, your diet is going to just be monitor your food, and so you can adjust your insulin. It's constantly this battle to not spike your insulin, and then your glucose levels, and then if you do, you need to adjust your your insulin treatment. Type 2 diet, you want to lose weight. Okay, so that's mainly what happens with type 2 diabetes is weight loss. Exercise. Well, type 1, your exercise is going to be pretty much like it's going to benefit you in the same way that it benefits other people. Type 2, the benefit of exercise is going to be weight loss, but it's also going to be the fact that if your glucose levels are high, this will help to to lower glucose levels, because exercise is going to you're burning glucose. Okay, so that's one of the things that's going on is you're burning glucose, and so your muscle cells will take it up, and you can use that as a way to decrease it. Almost works as kind of like insulin, except you're actually burning it. Okay, and it needs to be regular exercise, as you can imagine, not sporadic. So you need to have a regular exercise regime, maybe walking every night or something like that. Okay, so insulin, what does insulin do? Well, first of all, there are a few types. There's short acting, which is, the onset is within 30 minutes. Rapid acting is less than 30 minutes. And then long acting is going to take a little bit longer, onset of several hours, and it has a much longer duration. So if you're monitoring your blood glucose levels carefully, then it's best to use this combination of intermediate and immediate, acting. So the short and rapid. Um, if if you're not compliant, so if you're not really measuring this, then you're not going to be able to control it as well using the long acting. But it's I guess better than nothing is one way to say it. But it's going to last over an extended period of time, and that's, yeah, I guess better than nothing is a way to say it. But that's only if you're non-compliant. If you're really being careful, then you can kind of, get in there and really finesse your insulin levels, your blood glucose levels the best you can. Now there are pumps available, subcutaneous insulin infusion pumps, and they just approved an artificial pancreas, and I'm sure that'll take a while. So this is something that's actually available, but I'm sure it'll take a while to get that perfected. And so it's constantly sensing, and then it can activate the pump, and then the pump will administer insulin. So it's kind of trying to do the same job that your pancreas does. Okay, so some acute complications: diabetic ketoacidosis. We already mentioned that. If you're making glucose from triglycerides and if you're making glucose, from fatty acids, which are formed from triglycerides, and glycerol and amino acids, then you're going to be producing more ketones. Ketones are acidic, and that's where we get ketoacidosis. Okay, so your blood becomes more acidic. So clinical presentation, it usually is slow onset and a prolonged recovery. So also in terms of presentation, you're going to see 1 or 2 days of polyuria, polydipsia. So you're going to have increased excess urination, excess thirst, nausea, vomiting, some of the signs and symptoms associated with acidosis, marked fatigue, and it may, in some cases, progress to stupor and even coma if you don't get it under control. Characteristic fruity breath, because of these ketones are they're volatile, and they give off a fruity breath kind of odor. Abdominal tenderness, hypotension, so lowered blood pressure. Metabolic acidosis. Okay, so insulin resistance accompanies severe acidosis. Low-dose insulin therapy is indicated with frequent monitoring of serum glucose levels. Okay, so yes, this is an acidosis type of situation. And so you can see compensatory mechanisms: tachycardia, so your heart rate will increase, tachypnea, which means that your breathing rate will increase, and those are just sort of compensatory mechanisms to try to increase the pH. So yeah, I almost made that mistake. So you're trying to make it less acidic. Okay, so the mechanism, not too worried about knowing the exact mechanism. Um, you can read through that, but what I'm really interested in is what's going on with ketoacidosis. You should understand what's going on with that. And so the lack of insulin, the production of glucagon, and so you don't have enough glucose, but it's going to force the cells to produce glucose from alternate sources, and that means the amino acids, the glycerol, the fatty acids, and then that's going to increase this production of acidic ketone bodies. Excuse me. Okay. So another complication is hyperglycemic hyperosmotic state. Okay, so this can result in increased thirst, dehydration, um, some of those kinds of problems. It's going to increase your insulin resistance because you are hyperglycemic, which means you have excess blood glucose, and it's at such a level that it's actually causing a hyperosmotic state. This makes sense if you think about what's going on in the bloodstream. You have an increase in, I'll make these circular, you have an increase in glucose in here. Now, we've talked about what happens if you increase salt. So if you eat, a bunch of potato chips and French fries and you increase the amount of salt, then you're going to have to replace that by drinking more water. And when you drink more water, then you have an expansion, you have more blood volume. So the same kind of thing is going on here, except it's with glucose, which kind of compounds the problem because of the problems that overall that increased glucose can cause. So it's seen more frequently in individuals with uncontrolled type 2 diabetes. It's an insidious onset, so it may take a while to come on, and occurs most frequently in the elderly and is often mistaken for a stroke because it can cause these neurological manifestations. That can happen because your blood cells are going to shrink. All this glucose out here if we talk about what happens in the brain and you have these neurons, it's going to suck the water. That's what osmosis does. It's where you have more particles, it sort of sucks the water away from other areas. And so when you have all of this glucose out here, it's going to, suck the water out of neurons as well. Okay, so it's characterized by hyperglycemia, hyperosmolarity, which is going to, like I said, a little more gentle way of putting it, pulls water from cells. That's what this hyperosmolarity does, which can lead to dehydration. Okay, and then that's going to cause excessive thirst, which means you're putting more water in, and neurological signs and symptoms such as seizures, hemiparesis, aphasia, visual disturbances. And you're also going to see an increase in urination, so increase in thirst and urination. Okay, but there is no ketoacidosis, so that's I guess one good thing. But you're not going to see ketoacidosis with this. Precipitating factors that contribute to the development of this is an increased resistance to the effects of insulin. So basically, type 2 diabetes progression. So as it progresses, and you've sort of lost your locus of control, you've lost your ability to really control what's going on, and you don't realize it, you don't pick up on it right away, then this can develop, and you may not be aware of it until it really starts to cause some serious signs and symptoms, especially if you're not paying attention. Okay, so and excessive carbohydrate intake, obviously. If you're not able to control glucose and you're eating cupcakes for breakfast, lunch, and dinner, that's not going to be a good thing. So general hypoglycemia. Okay. Now remember, insulin is trying to decrease the glucose, and so if you take insulin and your blood glucose levels are not necessarily elevated, or you've taken insulin and then you forget whether you've taken it, then then that can cause a severe drop in blood glucose levels. Okay, so it's caused primarily, and this is going to be normally show up in type 1 or insulin dependent diabetics. So you end up with excess insulin in the blood. Okay, and that's going to cause below normal serum glucose levels. So precipitating factors that lead to this, insulin dose error, or maybe you just didn't eat. You've taken your insulin, but you're not eating. You're not putting glucose in, and so the insulin is just kind of continuing to remove the glucose from your blood. Increased exercise, you're burning more glucose. Somehow you're getting rid of glucose, obviously. Um, Decreased insulin need after the removal of a stress. So something that is, you may be increasing your insulin because of something, and then you don't decrease it because you don't have the need to decrease it. And let's see. So you have a decreased need for insulin, and yet you're still providing that insulin. So it's kind of doubling up on that. Medication dose changes, and then alcohol. Alcohol. This is the first place I ever saw this was in a bar, and there was a diabetic, and she was drinking too much, and so alcohol decreases liver gluconeogenesis and may cause hypoglycemia in some diabetics. Um, so this is going to lead to a decrease in glucose overall. So especially if consumed in large amounts or on an empty stomach. Okay, so rapid onset and progression of symptoms, a wide variation in the manifestation of signs and symptoms. Okay, so there's quite a bit going on there. Altered cerebral function, headache, difficulty making decisions, seizures, behavior disturbances, and coma. Peripheral nervous system activation, so you may feel hunger, which kind of makes sense if you don't have glucose, if you're hypoglycemic, and sympathetic nervous system activation, anxiety, tachycardia, sweating, vasoconstriction, and cool and clammy skin. So a lot of times we call this insulin shock, but of course shock refers to kind of hints at cardiovascular and drop of blood pressure, uh, which can happen. Okay. All right. So some other things, and this is just kind of something that's interesting and kind of hides. Okay, it's the Smogai effect, and Smogai, the person who discovered this, made this quote, and he said, "Hypoglycemia begets hyperglycemia." So when your glucose levels fall, you are going to have a rebound. And this rebound may not be, and I'm drawing the same graph that's over here. So as your glucose levels fall, then you sort of kick in compensatory mechanisms to increase that blood glucose. So what happens is that, like, okay, so if we look at this graph, at bedtime, the blood sugar is within range, okay? But yet the insulin may continue to have an effect, and it may prevent the addition of more glucose, and it may continue to cause glucose to be taken up. And so your glucose levels fall to dangerously low levels. And so in people with diabetes, insulin-induced hypoglycemia produces a compensatory increase in blood levels of catecholamines, glucagon, cortisol, and growth hormone. All of these things will contribute to increasing glucose. And so that's what you see. You see this drop, so a hypoglycemic event, followed by an increase in blood glucose. Okay. So these counter-regulatory hormones cause serum glucose levels to be elevated, and that can cause some degree of insulin resistance. Okay. And the thing is that it often occurs at night or at a time when it's not recognized, and so it's difficult to diagnose. So you're sleeping, your blood glucose levels fall to a very low level, and then they spike right after that. Okay, so something else that occurs that has been noticed is called the dawn phenomenon. And it's probably related in some way to this, but it's really not really known exactly what's going on with the dawn phenomenon because it's a phenomenon. And that occurs when, okay, so it occurs when there's an apparently unexplained morning rise in the fasting blood sugar, blood glucose levels. And so what you tend to see is your pre-breakfast level is higher than your pre-bedtime level. So at some point overnight, um, and it can be related, it's probably related to this, but your levels when you go to bed will be at one point, and then when you wake up, they could be elevated. Okay, and so that's called the dawn phenomenon. Okay, so complications, chronic complications of diabetes mellitus, microvascular complications, so it does a lot of damage to small blood vessels, macrovascular complications, which can include cardiovascular and cerebrovascular diseases, and then also not necessarily fitting under macrovascular complications, but important to understand because this is a serious problem, are I almost said foot odors, foot ulcers. This is a very long video. I apologize for that. So the exact causes are unknown, but there are three proposed mechanisms, and we're not going to get into that. But a lot of times it's simply the increased blood glucose is causing some kind of damage. Okay, and that's what's causing all of these things. It's causing damage to primarily blood vessels, but and also as nerves. Okay, so diabetic neuropathy. Okay, diabetic neuropathy. That tends to be caused or tends to result from microvascular damage. Remember, neurons need a blood supply too. Okay, so they need nutrients, they need oxygen, they need a blood supply too. And they are very small micro vessels that are doing this, very tiny capillaries. And so what happens with the high glucose levels is you end up with this thickening of the walls of these capillaries, of these nutrient vessels um, that supply the nerve with nutrients. And so it creates an ischemia. So you have this sort of this increase in the thickening of the walls. You tend to block the ability for nutrients to arrive. And so you have this decrease in oxygen levels. You have this decrease in other nutrients. And so eventually over time it can cause damage. It can cause damage to Schwann cells. So Schwann cells are going to allow neurons to be transmitted more quickly, and so those are broken down. You can kind of see from this picture. It's not a very good picture, but this is a so you have reduced blood flow, and then you end up damaging the neurons that it's supplying those nutrients to. So it can be somatic or it can be automatic or autonomic. Somatic just means it's associated with the body. So if you have a somatic, generally what we're talking about occurs first in the extremities, like in the feet. And you have this sort of diminished perception of vibration, pain, and temperature. Okay, so this is what's going on in the feet, where it's a long ways away and maybe blood flow is a little bit slower to begin with. It's usually bilateral, so it'll happen in both feet. And then it does progress to the other extremities, like the hands. So it often occurs in a stocking or a glove pattern, and so you kind of see this numbness that happens where you would normally have socks, okay, or gloves, and then it just sort of creeps up, and the socks get longer and longer. Okay, so that's what that's referring to. Which is pretty descriptive and kind of makes sense. You're losing neuron damage, or you're losing neuronal sensitivity in those areas. So from that, you have an increased risk of falling or burns, injuries to the feet, because you just don't have the sensation. Now there's also autonomic, which can have a defect in vasomotor responses. So we're talking about muscle control. So decrease in cardiac responses, impaired gastric motility. So this is going to be digestion, and hypersecretion, which can lead to diarrhea, inability to empty the bladder, and then sexual dysfunction. So diabetes is the leading physiological cause of sexual dysfunction. Okay. And let's see. So moving on, also related to microvascular are the tiny, teeny, tiny little blood cells that affect the eyes. And so we know that, or diabetes is a leading cause of blindness. And so it is the leading cause of blindness, of acquired blindness in the United States. And it really comes down again to poor glycemic control. These glucose tend to ultimately cause damage to these very, very tiny blood vessels. So poor glycemic control, elevated blood pressure, increased lipids in the blood. And so it's characterized by retinal hemorrhages, abnormal retinal, so bleeding, abnormal retinal vascular permeability, so leaking of the vessels, microaneurysms, which means that you're sort of exploding, or it's also going to cause destruction of blood vessels. New blood vessels are produced, and then the associated um, hemorrhage with that as well, scarring, and then retinal detachment. So the damage essentially comes down to the damage of these very small blood vessels. Okay. So macrovascular complications, diabetes is a major risk factor for coronary artery disease, stroke, peripheral vascular disease. So if we look at these and we break them down, coronary artery disease, what we're really talking about is this increase in atherosclerosis. Okay, so that tends to be a big problem, and you have this narrowing of the blood vessels, which makes it more difficult for blood to get through, and then you can also end up throwing clots. So this is so that's a real risk for people who have diabetes, especially those who have trouble controlling their diabetes. Multiple risk factors for vascular disease are present in individuals with diabetes. So that includes, and of course we come back to obesity, high blood pressure, high blood sugars, increased insulin, hyperlipid, so increased fats, altered platelet function, which can lead to more of the atherosclerosis, elevated fibrinogen levels, which can lead to clots as well. So platelets and clots that can develop from that. Okay, so if we, and just to revisit it one more time, we're talking about the increased risk of throwing a clot, which can cause stroke or can cause heart attacks as well. And then the last slide, finally, it's the longest video. Diabetic foot ulcers. Okay. Now, this can also come from a lot of feedback, a lot of vascular problems that are trying to supply blood flow to keep the tissues alive. And of course, it usually starts a long ways away in the periphery, specifically on the bottoms of the feet, or on the feet is where you first start seeing it. So distal, which means a long ways away, symmetric, which means it's going to occur on both feet at about the same time. So distal symmetric neuropathy is a major risk factor for foot ulcers. Okay, so neuropathy. So you've lost vascularization. You've lost particularly vascularization to the neurons. And then you become unaware of any kind of trauma or pain. So when the abnormal focus of pressure is coupled, so you can't measure the pressure, is coupled with a loss of sensation, so you're not walking properly, and you don't have the normal feedback sensation, then a foot ulcer can occur. And a person with diabetes should receive a full foot examination at least once a year. So it's very common with advanced stages of diabetes to have this develop, and then sometimes if you can't get it under control, then you'll have to have amputations. Okay, so somatosensory testing, how do they test it? The Sims-Weinstein monofilament. Basically, it's just this this little filament that you can poke, and you poke until it bends. And these are made to only bend when they've applied a specific amount of pressure. So in this case, the monofilament applies about 10 grams of pressure at the point of contact, and then you can kind of see at which point how much pressure is required before the person feels it. So it's kind of this little gauge. You push on it. When it bends, that means you've applied that much pressure for whichever one you happen to be using. And then 4 to 10 sites for impaired sensation. You kind of see those written out here. Okay, well that's the last slide of this very long, hopefully not boring, but probably lecture on this stuff, endocrine and diabetes.